The question is, could this outcome have been anticipated? And how could these questions help shed some light on these issues? So for this gentleman, which health conditions are easily treatable? Well, the lung cancer is easily removable and is curable with removal, but he also has chronic lung disease, chronic heart disease, and dementia, 3 diagnoses that are not easily treatable, all of which shorten life. How will frailty make treatment risky? Well, certainly we know that this gentleman is moderately frail at baseline, and his risks for surgery and getting home after are considerable. How can symptoms be safely and effectively managed? Well, in fact, he didn't have any symptoms from the lung cancer. It was found incidentally on the chest x-ray after he had a pneumonia. Will the proposed treatment improve function or memory? Well, I think we can all agree that removal of a cancer could not be expected to improve function or memory, particularly if it's not having any symptoms. Will the treatment require time in hospital? Certainly. And if so, for how long? That's difficult to predict in this case. But for this gentleman, he didn't end up going home again. Will the treatment allow more good quality years, especially at home? And again, I would stress that this is a situation where we're proposing a removal of a lung cancer that didn't have any symptoms associated with it, but the risks of surgery and after surgery were considerable. So one of the questions that really comes to mind here is, well, you know, maybe he did require more time in hospital and had to be placed in a nursing home, but surely the removal of the cancer would make this gentleman have a longer life expectancy. But in fact, if you look at people who have this type of lung cancer but aren't able to have the surgery and you follow them over time, what you find is that the overall survival at 2 years is 22 to 72%. So by removing the cancer, we haven't actually extended his life. So we haven't made any difference to life expectancy, but we've certainly had a huge impact on his quality of life. So the PATH Clinic was started through an innovation grant from the Capital District Health Authority. And using that grant, we developed print materials for patients and families that go through some of the issues that we talk about, because we recognize that not all the information can be provided, you know, while someone is at the clinic or while we're seeing them on the inpatient service. So the print materials describe frailty, dementia, decision-making tools. We actually have checklists and guides so that if someone's at the very end of life, you know, what are the steps we need to do, for example, as a family to ensure that someone has a good and dignified death, either at home or at hospital. So we have those checklists. And we also have wallet cards with the framework questions on them, because sometimes for caregivers, they'll put that in their wallet, and then when the emergency health services is there at the house at 2 in the morning, they can easily think, oh, that's where I have those questions that I need to make sure that I can answer to make a decision. We're also producing a film about the process itself and some of the patient and family stories that have been impacted by the process. So far we've seen 51 patients. Some of those have been outpatients and some of them have been inpatients. The average age has been about 80 years, and most of them have severe frailty or moderate dementia. And there have been 8 deaths since the PATH process was started in September of 2009. In terms of building the capacity, we recognize that approaching end-of-life decision-making in a tertiary care center is really a Hail Mary activity. Really the time for having these discussions is ideally when someone is in the community and has some indication that they're frail or there are issues going on that need to be discussed. We'd like to have more family physicians, primary care physicians participating in the process. And we can also see that the continuing care assessors have a huge role to play in terms of identifying people who are frail and may need to have some work done around decision making. We have expanded the PATH process beyond the 4 walls of the CDHA, however. We have a community health team, a multidisciplinary team in Lunenburg, who has been trained on the PATH process, and we work with them on a regular basis to help them with their assessment and care planning of patients. And we also have a collaboration with the R.K. MacDonald Nursing Home in Antigonish, where they're integrating the PATH process into their assessment when an individual comes to long-term care. We have many collaborators who have been working on this process, both within our clinic and beyond. And the conclusion that I hope you'll draw after seeing this presentation is that really our culture and our healthcare system face multiple challenges in terms of how we approach end-of-life care for people who are frail, and that the PATH Clinic might provide one model that could address some of those challenges. Also, that frail individuals like that 83-year-old gentleman with the lung cancer that was found may seem to be doing well, and what we should aim to do is to continue to support that good quality of life instead of perhaps risking that quality of life to provide interventions which may not be helpful in the long run. And really, new strategies and guidelines are needed in terms of how to approach decision making for people who have multiple medical issues at once. So that's the end of the formal part of the presentation, and if there are questions from the audience, I would be happy, or points that you would like to discuss.
Have any plans to commercialize this?
It does seem eminently commercializable. I think one of the main goals of the PATH process right now is to, as I've said, expand it beyond the CDHA. We need to ensure that it's portable, so that if I'm a primary care physician and I hear about this and think, I want to do that in my practice, that there is a clear model of how to implement that in primary care. So what we're working on right now is a handbook for primary care physicians with a companion handbook for patients and families, so that they could work through the process in a more primary care setting, which requires a lot of modification, right? Because family physicians have to have a lot of turnover in their practices in order to keep a roof over their heads. So we need to divide the process up into smaller bites. But really, the family physicians are ideally situated to do these assessments and have these discussions because they've known the person for many, many years. So that's the next step.